Um, I am introducing today my colleague, Dr. Umesh Venkatesan, who's been an Institute scientist with us since 2019, clinical neuropsychologist by training. Actually, by my training, we have had all the same training experiences leading up to MRRI, where he directs the Brain Injury and Behavior Laboratory, and will be presenting today an interesting talk based on his work on social determinants of health. And the talk is entitled From Social Determinants of Health to Private Experiences of Disability After Traumatic Brain Injury. Welcome.
Thank you. I may be drinking from this because I'm very hot, as some of you may be as well. Okay, so I'm very happy. Thank you, Dr. Rabinowitz. I'm very happy to be presenting on this work. It's still sort of in its sort of nascent, but taking some interesting directions with collaborators as well. Just some housekeeping business and appreciation. So today's lecture is sponsored by the Shrier family, topics in rehabilitation science. So we are very grateful to them. These are the CME information. The code should be there, and I will flash this again at the end of the talk for those who may have missed the beginning. Okay. We Institute scientists have no financial relationships to disclose, and I personally have no relationships to disclose. Okay, so the objectives are as they were on the flyer for the talk today. So we're going to talk about social determinants of health, which will be abbreviated as shown, and describe their importance to TBI rehab and management, discuss the role of personal or patient experiences of health and disability on behavioral health outcomes of traumatic brain injury, and then finally, demonstrate an understanding of the life course approach to evaluating and treating post-TBI health, and I'll talk a little bit more about that later. So what are social determinants of health? What are their definitions? I'm sure many of you have heard that. Show of hands, have you heard that term before or not? Okay, so a lot of you. So these refer to the conditions in the environments where people are born, live, learn, work, play, work, just about do everything, just about live, that affect a wide range of health functioning and quality of life outcomes and risks. And I bolded conditions here because that's what makes this pretty hard to measure. We often measure it with sort of these simple objective variables like education and things like that, but conditions really refers to quality, and that's a very difficult thing to measure. Social determinants of health have come into the limelight as of late in all of sort of medical sciences and also rehabilitation sciences, because they underlie, or they are thought to underlie, health disparities. So health disparities are the difference in which disadvantaged social groups such as the poor, racial, ethnic, minoritized groups, women, other groups who have persistently experienced social disadvantage, they systematically experience worse health or greater health risks than more advantaged groups. That's a very popular definition. And what is advantage or disadvantage? Well, it can be economic, it can be social, relative to your social hierarchical position in society, dictated by all of those factors listed there. And it can also be environmental. We think about this less, but it is, especially with climate change issues and things like that coming to the fore. So neighborhood, wealth, opportunity, resources, walkability, you might have heard of. So there are many different sources of health disparities or social determinants of health. There's tons of lists out there. These are a few of them from the National Academies of Sciences, Engineering, and Medicine. You know, they're anything socioeconomic, environmental that you can think of, and many different ways to measure this. As you can imagine, it's a very interdisciplinary study. There are, however, challenges to addressing health disparities, and I'm really just going to talk about one significant challenge here, which is sort of conceptualization. So much of healthcare still perpetuates the genetic origin of health disparities, despite race being a poor proxy for genetic differences. And I mentioned this particularly because when people think of social determinants and disparities, they automatically think of race, because race is the biggest disparity that we see in society and the thing that's therefore most often studied. And there are several different examples of this, of race being a poor proxy for genetic differences. So black-white differences in hypertension, thought to be attributed to genetics. But there's actually a gradient of prevalence from black populations in West Africa to the Caribbean and the US. We don't see the same prevalence of hypertension actually in Africa, even though they're sort of genetically more related to the Caribbean African population. And Black Africans actually have a lower prevalence than white Americans of hypertension, which sort of debunks the whole this is due to racial differences, right? Another example of this is correction algorithms. This came to the fore sort of on, if you were following Twitter in like 2020 and later, neuropsychology was also involved in this discussion. So dementia claims by Black NFL athletes or retirees, sorry, they were honored less frequently because they were assumed to perform lower at baseline because of the correction algorithms that we use. And therefore, it's harder to show a deficit when they're actually having problems. There were huge news stories about this. Also in medicine, there are great papers. This is one of them that goes through several correction algorithms that they use in medicine for like kidney functioning, heart functioning, et cetera, and how each one systematically inadvertently discriminates against minoritized groups. And they direct resources away from minoritized groups and actually direct them towards white patients. So there's a lot of different examples of that. Those are just a few. One I found interesting in doing research for this talk was from the National Conference of State Legislatures. So this is sort of it's a legislative organization. It's to coordinate sort of state policies between different states on many different topics, one of them being health. And so this is their sort of conceptualization of health disparities. So they say many factors contribute to health disparities, including genetics, access to care, poor quality of care, community features, et cetera, et cetera. I've already read the problem with that definition, and that's that. So that's not what health disparities are. They're not due to genetics. So there's often a fundamental misunderstanding of health disparities, and that this makes health equity work very, very challenging for rehabilitation and beyond. So I'm going to shift to a little bit about talking about disparities in TBI rehabilitation recovery. That's not the focus of this talk, but I think it's a good foundation. So with respect to TBI rehabilitation specifically, disadvantaged social groups are different from more advantaged groups with regards to a number of factors, including but not limited to the prevalence of diseases and comorbidities, mortality outcomes, and importantly, access to care. And disparities actually exist across the continuum of care, from why people are injured in the first place to their long-term chronic functioning. And here's a really good this is a figure from a recent paper that talks about disparity, that illustrates disparities through the continuum of care. So you can see right from the risks and mechanisms of injury. I don't know if this, oh, it does work. Yay. But it's laggy, so we won't do that. So right from the mechanism of injury, minoritized individuals, I think it's specifically talking about racial minorities here, are more likely to sustain TBI from violence. Increased exposure to adverse childhood experiences. I will talk more about those later. And then, of course, acute TBI, their acute care and acute rehab, longer wait times in the ED, more likely to receive testing for alcohol and things like that, and be suspected of certain issues that others may not be suspected of. Straight to rehabilitative services, lower quality of rehabilitation, less likely to even receive rehabilitation. Psychosocial adjustment, again, and all the things that go along with that and being a minoritized group. And then, of course, all of that leads to, not surprisingly, poorer functional outcomes. And less likely to be employed, and everything cascades after that. So I really like this sort of flow diagram that they've shown here. These are data from a different publication, also another recent publication. Specifically, these were pulled, I think, across 4 studies, and the reference group was an age and injury severity matched white group. And they looked at the different percent incidence increase of these different things, and the things that the bars that go to the positive direction are bad things, and the bars that go to the negative direction are the good things. And so you can see that the Black patients compared to white patients often have more violent TBI, poorer outcomes, and they don't get the rehabilitative services as much as privileged groups. Okay, so like I said before, social determinants underlie health disparities. So there's one thing to document health disparities, but then why? Why do those health disparities exist, right? So these social determinants ultimately refer to individual social factors with associated mechanisms, right? So there's relatively little work, though, that exists in TBI beyond documentation of racial and ethnic disparities. But it is a growing area of interest, and hence why it's an area of interest of mine. We also have to think of like race plus or intersectionality issues, so that there may be multiple marginalized identities within a person, being Black, being a woman, being disabled, all of these things that society sort of systematically, discriminates against, and they can all live multiple identities. These identities can live within one person, and this creates complex systems of oppression. But we have to consider those, even though it's difficult, especially statistically, but we have to consider them in how they may synergistically impact outcome. So there was a recent special issue in the Journal of Head Trauma Rehab on social determinants of health in TBI and implications for service delivery and outcomes. I'll talk a little bit following on some of the studies that came out of this. Our work was also featured in this too, but I'll get to that a little bit later because it was qualitatively different from the rest of the studies here. And this special issue was also the focus of a recent Brain Injury Association seminar on social determinants, where our work was featured as well. So a lot of the recent studies and the studies in the special issue focused on multiple sources of disparity, or multiple social determinants of health. So there was a study looking at racial disparities in pain severity and pain-related disability in folks with chronic TBI. And in addition to race, they found older age and lesser education contributed to pain-related disability. Another study, and this was sort of catch-all kind of TBI, so they looked at concussion, moderate severe TBI, all kinds of stuff. So there was another study that found that non-Hispanic Black concussion patients without private insurance, that tends to be another big thing that comes up, are less likely to adhere to doctors' recommendations than those with private insurance. And also another study that looked at neighborhoods. So they used something called the Area Deprivation Index. And remember that I said neighborhood was another social determinant. So this is sort of based on census data, and they characterize where people live. And so those with less resources in their neighborhoods, lower education in their neighborhoods, experienced greater symptom burden than those living in more advantaged neighborhoods after adjusting for a number of covariates. Our work in this issue was a little bit different, and I will talk about why, but first I want to talk about how these health disparities come to be, right? So I talked about underlying social determinants, right? So there are these economic, social, and environmental influences, these social determinants that we measure by education. Some of the more popular things now are like food and housing insecurity are coming to the fore and things like that. We measure these things, and then we look at how disparities come from them, right? But there's a critical in-between kind of step, which is the enacted and lived experiences of the people, how they experience these social determinants. It's not necessarily that every food insecure person experiences it the same way and therefore has poor outcomes. We know this is not true. There's individual differences, there's variability, there's resilience factors, things like that. And that together leads to these observed health disparities that we have between racial groups, between gender groups, et cetera, et cetera. And also parenthetically, it's a feedback mechanism, right, too? So when society observed these health disparities, they don't necessarily attribute it to the right things. So it perpetuates these economic and social influences, these compounds, these lived experiences, and it just goes in a cycle like that. So that's the parenthetical mark. Now, why I'm interested in this too is it's difficult to study, and people often ask, like, what can you do about it, right? If you find that there's social determinants, right? We are but researchers and rehabilitation researchers in a research institute. We're not even epidemiologists necessarily. We're studying these sort of mechanisms of functioning, right? So how are we going to change these things? Well, yes, in the red triangle, these are more structural interventions that you would need. You need societal interventions. You may collaborate. You can influence policy. God knows we need it with the definition I showed you from that state organization. So that's difficult. But why I'm interested in, especially being trained, as Amanda mentioned, as a psychologist and neuropsychologist, is this level, because this is the level where we can do individual interventions, taking into account, all of the structural problems and people in context. We can even take our existing interventions and improve upon them if we know the context in which people are living and what they're dealing with, especially when they get out of the hospital. So that's why I think we can, all the frustrations here, we can actually make some movement and move the needle there, I think, to impact that. So this got me interested on social influences on the disability experience. And I'm going to go into a small tangent, but I'm going to get right back. So the way I started looking at this first, I don't know if you all remember, if you were here in the 2020 topics in rehab science, I talked about memory functioning in TBI. And I was looking at PTA, predicting chronic memory functioning independently. So post-traumatic amnesia acutely predicting memory functioning. And I was like, this is so cool. And it still is, and we published it. But it got me thinking about these social influences on experiences, how people actually internalize their abilities or disabilities, et cetera. And it got me interested in this thing called memory self-efficacy. And I've talked to some of the staff about this before. And so this comes from self-efficacy theory. It actually comes from social cognitive theory. Bandura he was a psychologist, is social cognitive theory. And it talks about how all of these factors here on the left in the ovals influence people's self-efficacy judgments, basically how confident they are they can achieve a task or perform a task. So you can see here there are certainly some personal factors here, sort of performance accomplishments, sort of metacognitive monitoring and things like that, but also social experiences too that shape how people feel about themselves, how they experience the social environment, and then how that influences their functioning. So things like vicarious experience, modeling, and social persuasion. And all of these things influence each other too, even though there are arrows there. So it got me asking, we had data, we had not only from that same data set that I presented last time, we had not only memory functioning, but we also had ratings of how people thought their memory was. So we decided to look at that to see if that actually was related to their performance, controlling for various things. And so we did end up publishing this last year, with this title that kind of makes me cringe now, but it seemed cool before. We looked at the beliefs about memory ability and how that contributes to people's memory performance when you control for their depression and other things, other self-reported things that might influence performance, injury severity, et cetera, et cetera. And we actually found that memory beliefs modestly, but they do significantly predict memory performance, even after accounting for psychiatric distress, which tends to be a large predictor in these studies. And interestingly, we were interested in more large-scale outcomes like quality of life, because it's been found in other literature that what people believe about their cognition, and particularly their memory abilities, gets in the way of them engaging with the social environment and participating in life. And so we wanted to see if it was related to their quality of life uniquely. And we did this multivariate analyses, which I'm not going to go into, but we found that it was related to their health-related quality of life ratings in multiple domains. And particularly when you considered a couple domains together in a multivariate way, such as cognitive and social functioning. So this was kind of cool. It's sort of like a subjective, so it's a social, it's not related to racial disparities or anything like that. But again, social determinants do not presuppose that. They just say that there's social influences on your health, and that could be related to the measured functioning, the things that we measure, and we may not be capturing that. And this was just one demonstration of that. But then we did get more formally into things that might be contributing to health disparities, and that sparked an interest in stigma and discrimination. So stigma and discrimination, you all know what those terms mean, but they may be considered a form of chronic stress with biological, psychological, and psychosocial consequences. So there's a huge chronic stress literature about discrimination, lifetime discrimination, and how that has negative effects on health in many different aspects. Discrimination can be anticipated. So you have anxiety, you have a physiological stress response because you are anticipating that you're going to be stigmatized or discriminated. It can be actually perceived. So you're in the situation, or after the situation, you perceive that you were being stigmatized, or it can be internalized. So through many, many encounters with people who you perceive to discriminate against you, you internalize those feelings of lack of self-worth and blame and things like that due to your own disability. You tend to believe what people have been telling you. It can be attributed to a single or multiple sources. So it can be due to race, or gender or anything like that, but it can also be due, obviously, to disability, visible disability. And it's hypothesized to contribute to health disparities in physical and mental health through all of these mechanisms, these biological, psychological, and psychosocial mechanisms. With respect to disability stigma in traumatic brain injury, there hasn't been a whole lot done at all. A lot of the work has been qualitative. There are a couple studies previously. So one found that self-reported, all of this is self-reported, obviously, disability stigma led to poor societal participation or community integration among those with, I think it was TBI of different severity, and also social anxiety and isolation as well in a couple studies. So we decided to look at this as well in a data set that we had with Penn State. We had questionnaires relating to experiences of discrimination. So my colleague published a paper earlier on discrimination. We found a relationship between discrimination among folks with TBI and blood pressure. They had higher pulse pressure if they reported more major experiences of discrimination. And then we most recently, and this was the paper that was in this special issue, effects of perceived discrimination on behavioral health outcomes. So this was more of a physiological outcome, and we were looking at different behavioral health outcomes here. So I'll talk a little bit about that now. We examined relationships between major experiences of discrimination, everyday experiences of discrimination, and a number of outcomes, and I'll explain what major experiences are. So that questionnaire, it's from David Williams at Harvard, and it's a very popular questionnaire. It asks the participant to rate their experiences, sort of major, denied housing or denied a loan, like these things that don't happen every day, right? So they come around once in a while, but they can have sort of a profound impact on your life and course and things like that. So those are major experiences. Everyday experiences refers to sort of everyday slights, everyday little injustices, sort of we might think of them as they're akin to microaggressions. You've all heard that term. Treated unfairly at a restaurant, not spoken to directly, treated less, those kinds of things. So they're sort of qualitatively different in what they're asking the participant. So we looked at cognition measured objectively through neuropsychological testing. We looked at psychological symptoms, depression, anxiety, etc. We looked at neurobehavioral symptoms like apathy, and other sort of frontal dysexecutive symptoms, participation, like the other study did, and also health-related quality of life. What we found that while both seem to be in sort of bivariate relationships, both seem to be related to these outcomes, except it was the everyday experiences, the sort of continuous slights, the cumulative kind of discriminatory experiences that were related to these psychosocial outcomes, which makes sense because that's what these outcomes are measuring too, not sort of one and done events. And so there were appreciable effect sizes with this. And this wasn't an analytically complicated study or anything like that, but we did control for injury severity, age, we controlled for race as well. We looked, now in this particular sample, we had about, I think, a quarter of the sample was Black. We only had Black and white individuals in this sample, some identifying as Latinx, but we didn't have a difference in the reported level of discrimination, either major or everyday experiences in this sample. So that's just one thing to keep in mind. And that's because we did not, and that may be because we didn't query specifically about racial discrimination. These questionnaires are supposed to be broad. They were sort of built on the idea that some people cannot identify their source of discrimination. They just know they're being treated unfairly. They don't necessarily know why. And we're looking at a clinical sample, so it could be a number of reasons why. So we did ask them, we collect qualitative data on what the sources of discrimination are. There were various sources, gender, race, you know, a lot of different, just socioeconomic status, being perceived to be poor.
And disability.
And disability, yeah. Disability. Did I not say that? Yes, disability as well. So disability was in there. It was, I don't think it was by any means like the number one thing. It was just one of the list. So it was hard to tease out which was number one, but we did look to, I won't talk too much of this because we're still going to be looking at this data, but in a small sample, we did look at neighborhood disadvantage. So we geocoded their addresses and we did a principal component analysis on the census, the American Community Survey data. For their individual geocodes. And if you extract that first principal component from those, from a certain variables, it's like households that make less than 25K, you know, less than high school education, et cetera, you get a sort of neighborhood deprivation score. And the higher the deprivation score for that neighborhood, the worse their neighborhood socioeconomic status is thought to be. So that was associated with poor cognitive performance and reduced societal participation, which were interesting findings. But this was a small, like a sample of about 29 or 30, but it wasn't associated with discrimination.
Can I?
Yeah.
Did you account for family support or that kind of stuff?
Yeah, we didn't have, that's a really good question. We did not have family support or caregiver like data in this. Yeah. There actually, now that you bring it up, we actually do have we do have like a familialism questionnaire, although I'm not quite sure what that measures.
That's like I know that's a measure of sort of cultural differences and affiliation with family, and it's included because it's considered one of the kind of cultural mechanistic variables that might explain certain certain observed differences between Latino.
But it's not support, right?
No, we have like living situation, which is like, you know, indicates whether they're living with a caregiver or spouse.
You have marital status. But no, we did not look at that in this.
Because it might not influence. I'm not sure if it would influence perception, but
what could influence?
Like support, family support.
Oh, family support, right?
But it definitely looks like it would influence the effect of that perception.
Right, and it's like that intermediate level of analysis. You have like the patient variables and then their immediate environment, which includes their social support and all that, and then their broader environment. So it could be a moderator of some of that, the impact of some of that content.
Yeah, they could be a buffer. It could make it worse if they don't have it, right? Yeah, that's very true. It's involved in a grant submission recently looking at, we're going to look at, I'm doing the stigma aim, but they're looking at dyads. So caregiver patient dyads and how that influenced stigma of and discrimination experiences and perceptions of the patient, but also of the like affiliate stigma as well. So by association. So it speaks to a little bit of that. We might want to go back to this and see if there's something like that there. So where was it? Oh, okay. So so those are some of the findings from that paper. And so we're continuing to investigate, sort of these subjective experiences of social determinants of health and how that, and not just the objective variables like their socioeconomic status or education, because we find that that might be more proximal to the actual outcomes that we're measuring. And the other thing that I wanted to talk about in another direction that we're looking at are sort of what I'm calling the life course social determinants of health. So there's a large literature on childhood, family, and social environments influencing later cognitive and emotional functioning. Interestingly, a lot of this has been done on parental mortality in childhood adolescence and how that affects later life cognitive decline and dementia. But also as of late, there's a lot of work on adverse childhood experiences. I mentioned this in an earlier slide. So what are these? These are potentially traumatic events that occur in childhood, such as experiencing violence, abuse, or neglect. And these are interesting because studies have time and again demonstrated that there are significant health consequences of these adverse childhood experiences, that they have long-reaching effects throughout the lifetime. So the initial study that was done by Kaiser Permanente in the San Diego area, and this was surprising because this was a mostly affluent area, but they still found a relatively high rate of adverse childhood experiences being reported. They found a dose-response relationship between the number of experiences that people reported and the risk for behavioral health and mental and medical conditions. So this is like depression, substance abuse, hypertension, all kinds of stuff. And these health consequences have been substantiated by later cross-sectional longitudinal meta-analytic work. People have looked at, most recently, increased risk for dementia, diabetes, hypertension, all sorts of things. However, what really tends to come out a lot of the time is mental illness for kind of obvious reasons, right? So it's among the greatest health risks. And even studies that primarily focus on medical morbidities like diabetes and hypertension and their relation to ACEs also report these secondary analyses where mental illness had the highest, the greatest effect sizes. So there's some work. Why I was interested in this is because there's some work, there was a scoping review that came out in 2017 that reviewed a few different studies and found that higher ACE exposure increases risk of sustaining a later traumatic brain injury. Now they were doing like a retrospective review. This wasn't sort of prospectively documented TBI, but they found that there might be a relationship here between ACE exposure and the risk for having a TBI in the first place. One proposed
is that mediated by substance abuse or any other risk factor?
Yeah, they haven't done those analyses. I mean, that's one of the hypotheses. So there's another one here, which is aggressive behavior too. So getting into risky situations, which might also go along with some substance abuse and things like that. So that, being in these environments, these tend to be chaotic environments, both in the neighborhood and at the home, may, modeling behavior and all sorts of things, substance abuse risk factors, family mental, all of these things may contribute to later being in situations where you're more liable to sustain a brain injury. But pre-morbid, what I mean by pre-morbid is pre-injury. So pre-injury stress and trauma are not well captured in human TBI studies at all. So we decided to do this with the Einstein Society grant that I got a year or two ago. We looked at ACEs in a sample of our model systems enrollees. So we looked at household and community ACEs, and I'll explain what those are, in a local sample of individuals with chronic, moderate to severe brain injury. We had a couple aims. One was to estimate the sort of as a pilot prevalence of household and community ACEs in a sample of adults with moderate severe brain injury, and also examine the relationship between these experiences and two principal outcomes, long-term outcomes that we often look at: psychological symptomatology and health-related quality of life. These are the household level and community level ACEs. The left side, the household level ACEs, are sort of what people think of as the typical ACEs. Those are what were measured in this initial San Diego study from '98. And since then, the Burfus uses this as well. Oops. For some reason, this slide is on a timer. I don't know why. But these were supplemented by the Philadelphia ACE Task Force. Yes, there's a Philadelphia ACE Task Force, and they have looked at the Philadelphia population specifically to, I know I was doing that, to see what other factors that could be considered adverse childhood experiences influence health outcome. And they came up with these community level ACEs, witnessing violence, felt discrimination, which we talked about earlier, and neighborhood insecurity, being bullied, and being in foster care. They found that those were really important things to capture specifically for a Philadelphia population. And they did find, they've done sort of population-based studies in the Philadelphia area, finding that these two ACE, they may predict different things, different outcomes, such as substance abuse, like mental health, substance abuse, etc. So it's interesting. So we used that questionnaire because it was appropriate for our population. In terms of the results, we found that the medians are not too important. It's just sort of the distribution that I want you to pay attention to more. So in terms of the household level ACEs, what was on the left, 80%, this is not a large sample, it was 85 people, but 80% reported at least one, and 68% reported at least one community ACE. The Philadelphia medians, or Philadelphia percentages for these about 50 report at least one of each. So this is higher than that. Of course, this is a small sample. I will mention though, this is quite a diverse sample. It was almost 50% Black and brown, which the majority of that being Black. We did also, one reason for that is we didn't exclude people on substance abuse history or mental health history, because then we would just be excluding the sample that we want to study. And I think that might have been one reason why we ended up with quite a diverse sample too. So this just goes to show you the selection bias in our study that really influences who we end up with in our sample. And the total number of ACEs, when you combine the two, was 4, and 88% reported at least one, which is, again, is higher than the Philadelphia population estimate. Like I said, one of the aims too was to look at how they're related to our some of our outcomes, like our psychological distress outcomes, and the subdomains and health-related quality of life. They were related to all of them, and they continue to be related to them even when we controlled for injury severity and things like that. And I have it here. So modest effects, 14% additional variance in global psychological distress, 8% in health-related quality of life. But remember, these are ACEs. These are things that happened before the age of 18, and these people are an average of 50 years old now. So that's quite remarkable that we're seeing that. We also did exploratorily, may have just made up that word, did a mediation analysis because there's literature to support that the effect between ACEs and what people report as their quality of life now may be mediated by their psychological distress. That just tends to come out a lot. That may be the most proximal thing. So we wanted to see, while we control for all of these things, does the center effect still hold when we do the, yeah.
I just wanted to point out another thing that I'm sure you know about from a neuroscience perspective. There's an increasing literature that shows delayed consequences of early ACEs on brain function, connectivity, activation, executive function, on all kinds of, so that's another way of looking at the mediation, is that there are biological changes in brain functioning in people who have stress.
Right. Absolutely. Yes. There are. We're not directly measuring any of those biological variables here, but that's definitely there. Like I talked about the physiological, biological stress responses, and they accumulate, right? And so you may not, and they accumulate over time. There might be a critical threshold or something where they sort of manifest what you're talking about, delayed. So yeah, all of those things are quite important. But we did find that this effect did hold. So there was psychological distress did mediate almost all of that effect between ACEs and health-related quality of life, whether or not we adjusted for these models and used bootstrapping. I'm just mindful of time. So just a couple of, a few research considerations when doing this work that came up. I always try to remind myself that adverse childhood experiences are not trauma. They don't equal trauma is what I'm trying to say. So I highlighted the definition earlier when it said potentially traumatic experiences. So we're not actually studying trauma until we ask people and query them on symptoms that they had related to those experiences. Until we do that, they're experiences and they're related to stuff, but we don't know the processes behind them. We don't know how they still experience them or think about them and how that's related to outcome. And everything's experienced differently by each individual. So we can't call it trauma.
So how are you defining trauma here? What do you mean by trauma? Because I mean, wouldn't an adverse childhood experience cause trauma?
It doesn't have to. So it's a trauma, it's a potentially traumatic event. It's a trauma exposure.
It's an
But-
environmental
yeah.
exposure.
Right.
And that to diagnose something as being psychologically traumatic, it would have to have this symptomatic manifestation. And he's just making the point that we haven't
Right.
measured that. We just say that there's an exposure of a potentially traumatic event, but it doesn't mean that these people have a PTSD response or some,
So that's the metaphor I was going to use. Several people go off to war, not everyone comes back with PTSD, right? Even if they have the same amount of combat exposure. So some have been traumatized, others have been exposed to trauma, but they don't live out those trauma reactions. Does that make sense?
Yeah.
Like anything else, these experiences are proxies for systemic disadvantage, just like other social determinants of health. They're just events. And so we have to look at processes, we have to look at biological, mediators and things like that to see how they're impacting our outcome and design interventions based on that. I guess I just said that. And accumulation, allostatic load throughout the lifetime. That leads us to this term life course theory and approach. It's not my term, it's a term that exists, a theory that exists. So this says that there's additive and interactive biological and social exposures throughout the lifespan, and these influence later health and contribute to health disparities. They build on one another, but they also sort of interact with each other. So you get this synergistic cumulative response later on. And there's sort of two components to this, especially when thinking about health disparities. So early shifting of health trajectories by stressors, and this refers to basically developmental periods like ACEs, when formative periods in a person's life, and also later risk and resource allocation by society based on social identity and position. So this is talking about later life structural marginalization and things like that. So both of these things, both the developmental period and societal influences in the adult period contribute or comprise the life course theory and contribute to outcomes. So why does this matter? Some people ask, well, these things are they matter in neurotypical people, right? Like if people are poor or have adverse childhood experiences or witness violence or abused or things, it's going to affect their health, no matter if they had a brain injury or not. Why do we care about it in brain injury or any clinical population? But the fact of the matter is that what we study as TBI outcomes, things like community integration, that's not unique to TBI. They are life course outcomes. We're studying how well are they socializing and things like that. That's not wholly dependent on their TBI. It's dependent on who they were before, all their experiences leading up to the TBI and afterwards. So it's sort of naive of us to think that we can just isolate the TBI and then we can figure out how to community integrate them from that. So the brain injury is another life event in a series of life events, right? It's not supposed to all come at once, but here it is. So observed health could reflect accumulative or interactive factors. They may necessitate trauma-informed care. If you've not heard this term before, it's sort of like a care model, right? For how to, first of all, be aware of patients' trauma and how to deliver treatment in a way that does not re-traumatize them. And so it's sort of an intervention mostly for the care provider and health systems to basically be culturally sensitive, just in a different way. and failure to consider chronic non-traumatic brain injury sources of health problems may result in setting inappropriate rehabilitation goals, expecting things of them that didn't even exist even before the injury, right? Conditions that didn't exist. Alliance ruptures, that's a therapeutic term we use. Poor rehabilitation engagement, so they're just not connecting with the therapist or the physician to achieve optimal rehabilitation success. And then, of course, the cascading problems that are associated with that due to poor initial rehab care. We know that's going to lead to poorer problems later on, as in the continuum of care I showed you later. And actually, a lot of people are wary about asking these questions of patients, but at least when people have sort of gotten over the acute effects of brain injury and are medically stable, many patients actually appreciate being asked about this, and they do themselves think it's important to their recovery. So we should probably think it's important to their recovery too. In our lab at Moss, and also the model systems generally too, we're really interested in examining social determinants more deeply in brain injury. We're learning about them. And so we have some planned work, ongoing work that we're going to have some data. I didn't want to present it right now since it's going to be published, but subjective experiences of social determinants of health, such as disability, stigma, institutional mistrust. We have some data on that as well. Lifetime trauma adversity, and also neighborhood disadvantage, like I talked to you about the neighborhood socioeconomic status. And this is just a little depiction of what that entails. So this is Philadelphia, you didn't recognize it. And this is the neighborhood deprivation index. So you can get this, I ran this in R to get this map, but basically the lighter the color of the area, the more deprived that neighborhood is according to those key census variables that were identified. You can see sort of the areas that pop out are the areas you might expect in terms of that. They're also the most minoritized areas. So, and so these are sort of the scores that we're looking at.
What's that little yellow spot that's sort of in the southern?
That's pretty south.
That's part of
Wait, the yellow, what?
This thing?
What color?
The central yellow.
No, I'm talking about the southern yellow.
This?
That little yellow spot.
This one.
This
Below.
one, yeah, that one.
It seems like there's a good
Right, like grayish berry, maybe.
except that one is like a yellow spot in the middle
I
of it.
think it's great.
Yeah, I don't know.
What is the yellow? You said that the light.
Yellow is worse.
Yellow is worse, so that, yeah, that's a little bit. Yeah.
Is that the airport area?
No,
That's
that's
saying
further
grayish
south.
berry south.
Yes,
Yeah.
yeah. Yeah. So it's also based on, this particular map is based on 2018 data. We've rerun it for 2020 and 22. It's depending on when the ACS becomes available. And this.
I
This is
can't
just
tell whether
general
the yellow is on
census data. This has nothing to do with our
the west
patients.
side of the river.
But yeah. But yes, you're right. There is sort of like a confluence here and just sort of random things here. Yeah. So we're doing more work with this, and the model systems also has a geosig, and they're also doing work with this on a national level. And I've got 10 minutes left, so I'm on my key point slide, so that's good. So a few take homes from this that I hope you go home with is social determinants of health threaten translation and success of TBI rehabilitation interventions. It's important to capture objectively measured determinants as well as subjective experiences, how people are receiving these determinants. Not all determinants are in fact determining for each individual. A life course approach can be really useful in this population, just about any clinical population, and it may contribute both to scientific understanding and rehabilitative care at the same time, actually. And I think psychologists and other behavioral health professionals are uniquely positioned to address issues of social determinants in post-TBI health, for example, related to patient empowerment, staff education, on both sides of the care. I have some acknowledgements. Some of these people are in the room. And thank you to our funders. And thank you. And here's the CE information again.
Actually, the the view is covering some of it.
Oh, we can't hear you, Eileen.
Actually, the view is covering, it's
Do
5.2
we hear
SEM.
anybody over there? Do we have the speaker on? I don't know.
I'm not sure.
Yeah.
You could ask them to type it in the chat.
Yeah.
Yeah, if anyone, oh, there is a chat actually too. Just missed EED code. Okay, she got it.
Oh,
Yeah.
And so, at the start of this interesting presentation and information for that, thanks. At the start of the talk, you began with the social determinants of health, and then you had this kind of schematic that you drew that ended up being circular,
Mhm.
and it had this triangle with all the sort of known factors of that we know influence the outcome. And so presumably there's a lot there. There's some that you may not know of yet that haven't been captured. And there's some interaction between some of those as well. And then you made I'm just trying to work through my understanding of this. And you made a case that, and so the first thing that comes to mind is, I'd love to see that in a pie chart where they're, rated by importance, where some of the weighting of some of these factors would be really important, known to be important versus other factors. And then that could ultimately, that's interesting in its own right, and might ultimately be a source to target for an intervention. But you made a point about the individual's perception, their glasses through which they see all of these things, which I think is really interesting, actually. And so the question is, I guess, is there any evidence that your perception can override some of that and is a worthy target for intervention by altering people's perception and the way that they view this, as opposed to trying to invest time in changing some of the social factors themselves?
Well, I think we have to do both, right? I think we have to work together to do both, but different sets of people are going to be doing both. So like, we definitely have to change the social factors and institutions. Those will take longer time. There's a lot more red tape to do that. But when you have, I feel like when you have the patient in front of you, at the very least, what we don't do oftentimes is even just do an assessment to understand these social determinants within the person.
So do you think is there any evidence that exists that you can change perception in a meaningful way?
I mean, there's evidence, like, so I've talked about self-efficacy before. So there's evidence that you can change perception that way.
I mean, in general, cognitive behavioral therapy.
Yeah.
To discuss the whole premise.
Yeah, but I
that
think-
you can change
But
perception.
I think even just the framing on changing the perception of the patient is sort of not like kind of bearing the brunt of what these
Yeah.
structural inequalities
Yeah.
are. And it's like, I think that to some extent, the frame, I mean, when you think about just thinking, obviously the structural interventions are critical, but bigger and probably better thought of by people outside of this room. But on the individual intervention level, I think it's just having a full awareness of that context to build alliance and do collaborative goal
Right,
setting and
exactly.
contextualize your treatment. Like, we know that rehab works when there's shared, when there are patient-centered goals, right? When the treatment is contextualized with respect to the environment in which they have to return to. And I think a lot of times our framing makes assumptions about patients' environments that might not hold for a lot of patients. So I think that that's where, at the individual level, thinking about the things we know about, like contextualizing behavioral interventions and setting goals, we can harness our expertise to understand how to do that in a way that has more attention to these disparities, which, I mean, thinking about like our behavioral activation treatment, or we're doing the physical activity intervention treatment, you tell somebody to, go home and take a walk in their neighborhood, and they say, I can't take a walk in my neighborhood, it's not safe, right? So it's like, even just thinking about something that you think is like a benign goal, it might not be appropriate.
Yeah, goal and success to that individual is
Right.
different from what we might think it is. And so I think we might give treatments where we define success the same way for each person, but that's not necessarily what they're looking for or appropriate for them, given their experiences. So I think, recalibrating, redefining,
Right.
understanding each individual better.
Right, and building
Yeah.
into our interventions, like ways to accommodate barriers to care, right? Because like financial transportation limitations, like all of these things that
Right.
prevent people from accessing
We've-
services.
We find out those things sometimes incidentally, right? Like the patient brings it, like they're not, sort of while we're trying to do, we're like, oh, they can't do it, we don't have formalized assessment procedures, things like that to suss out some of these things and predict that these are gonna be problems
It's
for
nice
people.
to know that before they've already like failed.
Right,
had,
exactly.
like, struggled in treatment
Yeah.
for months and
Because
months.
that itself is alliance rupturing, right? Once you fail once, it's hard to get it back.
But I was addressing more directly, I think, Dylan, I thought you were asking about self-perception of trauma. And
Not trauma, up the social determinants, I guess. I guess that would be trauma, yeah. No, disentangling their earlier pre-morbid trauma, just from the context facing them right now, and whether you can, so as they interact with all of these things in the red triangle, and their intervention then is to help them deal with that current state. And I guess you answered it by saying that's how cognitive therapy works, in terms of you can help them deal with their perceptions of things.
I mean, I don't think, these are such complex problems that it's not either or. I mean, I think what these guys are talking about is much more sort of intervening at the level of the healthcare system, which is what, how we can make sure that we take into account these environmental and social economic determinants. But then, of course, then at the level of how individual perceive these events, that might be a different intervention.
Right.
So it's just like, with the treatment specification, RTSS, what's your target?
What's your target?
Yeah.
And then what's the treatment to address that?
Yeah.
So really piggybacking on this is, I'm not a psychologist, just let me say this first. Do we really want to change the perception of that adverse event, or is it because if you try to change the perception, someone like me would say, you're invalidating my experience.
No, I'm not, and let's be clear, that's good to be clear. It's not to say those events didn't happen to you or that they're unimportant to you. They are important, they affected you, and in fact, it's educational. I mean, these events happen to you, they are, this is part of why you feel this reaction, this, that, that kind of
And
thing.
there's also
That very validating is the point.
And there's also acceptance and commitment therapy, which has emerged as like a newer way of cognitive behavioral. There's some things where we're not going to try to change your cognitions over what happened and convince you that they're irrational or that they're maladaptive. Instead, we're going to accept that, those things happen and they're valid and you have those feelings, and now let's commit to what you value and what you want to do to move forward. So it's kind of like just a shoe, that whole argument aside.
Good way to put it.
Can I ask some question?
And thank you, I agree with all of that. Eileen has something in the chat. Early in discussion, you mentioned discharge home as if it weren't good, and long LT care was a good. I do not think of it as such at all.
Let me explain what I
don't think it's the
mean.
place of discharge. I think it's the amount of time and it's the length of rehab stay. Is that what?
Yeah, it was the length of
duration of rehab.
It was the duration of, no, I didn't mean that, if they get to go home earlier, maybe they'd be doing well, and that's bad. I just meant that on average, they have shorter rehab stays.
Because the way
And that's thought to be,
Because
at least in these folks, due to not getting enough rehab, not that they were doing so well that they could just be discharged early. So sorry, I did not mean that.
it mentioned, I think in one of the,
Also,
one
whether
of those-
perception does or does not reflect the reality makes a difference. Person may be overly sensitive or conversely may be oblivious.
Umi, can you hear? Can you hear us?
And someone says they can hear Eileen, but the group can't.
Oh,
So-
we can't hear her in here.
Yeah.
I think we're actually at time.
Yeah, we are at time. I mean, these are good points. I mean, it's a reason why we have to evaluate each person and their how they're interpreting situations and things like that. And if something doesn't align with reality, that's actually more of a case for doing an intervention to change their perception. That actually has a stronger foundation there. No, John, I cannot hear anyone on Zoom. I'm sorry.
Is there, has this muted everyone?
Maybe,
Yeah.
you go to participants, go to participants, and bottom participant.
Okay, that's not.
You click on participants.
We have to.
It looks like everybody's already.
Yeah.
What now? Somebody talk?
This is Eileen. So it was early on in one of those columns of things, above or below. If what you meant was the time in inpatient, outpatient rehab, that's one thing. Long-term care to me means you're going to a long-term care facility. And in fact, this is an area where things can get a little more complex because often people from, we'll just call it more disadvantaged areas, lower income, qualify for services through the waiver, and they can have a paid caregiver at home so they can go home, and they can get transportation, whereas people who don't qualify for Medicaid may not have a caregiver available to them. Their loved ones may be at work and not able to stop doing so, and they don't automatically get the transportation. So, I mean, it can be a little more complicated.
Right, I was basically referring to time in rehab, just shorter length of stay in rehab, getting rehabilitation care.
And people were equated for severity?
Yes, they were. So I think that's time.
Yeah, we're over time. We have
Yeah,
another
we're gonna-
meeting.
But thank you everyone
Thanks,
for
everyone.
joining.
What-
All right.
What do I do with?